Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Grazie per essere con noi oggi su canale Anesthesia and Perioperative Medicine. Gracias por acompañarnos hoy en el canal de Anestesia y Medicina Perioperatoria. आज Anesthesia और Perioperative Medicine channel पर हमारे साथ जुड़ने के लिए धन्यवाद. Okay, let's dive right in. Today, we're going to build a complete perioperative playbook for managing our Jehovah's Witness patients. We'll start with the why, the foundational beliefs that drive their decisions. Then we'll move through preoperative optimization, intraoperative techniques, pharmacology, and finally we'll see how all these principles come together in one of the toughest surgical scenarios you can face. You know, to really provide the best possible care and to be a true partner to our patients, we have to start by understanding the why. This isn't just about a single rule they follow. It's about a deeply held conviction rooted in over a century of religious history that guides their most critical healthcare decisions. So this absolute refusal of blood transfusion isn't just some arbitrary rule. It comes from a very literal interpretation of several biblical passages. And this one, from the book of Acts, is a real cornerstone. It commands believers to abstain from blood. For Jehovah's Witnesses, this is nothing less than a divine law. Think about that. They place accepting a blood transfusion on the exact same level of sin as idolatry. Now, what's really fascinating here is that the Church's stance on medical procedures has actually evolved over time. You can see the ban on transfusions was formalized in the mid-1940s, but look at the big shift on organ transplants. At first, they were forbidden, basically seen as a form of cannibalism, but later that changed to a matter of personal conscience. The leadership explains these shifts as God's progressive revelations, meaning their understanding of Scripture is refined over time. So let's really break down these core beliefs. For Jehovah's Witness, blood represents life itself, which makes it sacred to God. The key interpretation for us is that a medical transfusion is spiritually the exact same thing as eating blood, which is strictly forbidden. And this ban applies not just to whole blood, but to its four main components: red cells, white cells, platelets, and plasma. The spiritual stakes here are incredibly high. They believe accepting a prohibited transfusion could literally jeopardize their soul. Now, of course, our role is to respect our patients' beliefs, not to debate them. But from a clinical standpoint, it's really useful to be aware of the internal logic and some of the external critiques. For instance, the most clinically relevant point for us is that distinction they make between major components and minor fractions. Allowing fractions, which of course come from the very same prohibited donor blood, is seen by some as a contradiction, but it creates a critical therapeutic window that we can work with, as we're about to see. All right, let's get practical. This is where we translate all that theology into an actual treatment plan. It is absolutely crucial to understand the clear no's, the definite yeses, and the all-important gray areas where the patient's individual conscience is the final decider. Okay, this table right here, this is basically our cheat sheet. The prohibited category is completely off the table, and the permitted category gives us our foundational tools. But the most critical area for us to focus on is that one in the middle, matter of conscience. You have to have a detailed, specific conversation about every single one of these items. Never, ever assume you know what a patient will or won't accept. So let's zoom in on those fractions. The official justification for allowing these is based on an analogy, the natural transfer of plasma proteins, like albumin, from a mother to her baby across the placenta. This theological framework allows individuals to accept products like albumin, immunoglobulins, and even specific clotting factors like factor VIII, fibrinogen concentrate, or cryo. But, and this is a huge but, it is intensely personal. One patient might be fine with albumin but refuse cryoprecipitate. You have to clarify and document this preoperatively. This slide highlights another absolutely critical principle, the closed circuit rule for the patient's own blood. Basically, their blood can leave their body, but only if the tubing remains continuously connected to their vascular system. Think of it like a temporary extension of their circulation. This is what makes things like cell salvage, or ANH, acceptable. But pre-donating their own blood for storage? Absolutely forbidden. The moment it's stored in a bag, it's no longer considered part of that. As clinicians, these cases put us smack in the middle of a classic ethical dilemma. It's the tightrope we walk, right? On one side, we have our profound duty to respect the autonomy of a competent adult. On the other, we have the principle of beneficence, our duty to do what's in the patient's best medical interest. Navigating this tension requires crystal clear communication, a solid understanding of the law, and a focus on what we can do, not what we can't. So how do we navigate this? Well, we have tools. A well-written advance directive is our best legal guide. Those wallet cards are common, but they might not hold up in court if there's any question about informed consent. When it comes to children, it's a different story. Courts will almost always authorize a life-saving transfusion. And, maybe most importantly, always involve the hospital liaison committees. They are your best friend, trained liaisons who can help ensure communication is clear and non-coercive. Okay, we've mapped out the boundaries. Now let's start building our active strategy. Success in bloodless surgery really begins long before the patient ever sees the inside of an operating room. A solid preoperative plan is all about maximizing the patient's own physiological reserve to withstand any potential blood loss.
So what's our single biggest goal before we even think about surgery? It's all about that hemoglobin. We know that anemia is one of the strongest predictors for needing a transfusion, so correcting it isn't just a nice to have, it's absolutely essential. We want our patient walking into the OR with the highest, safest hemoglobin level we can possibly get them to.
Think of this as a multi-step mission. It starts with a detailed, confidential chat to document exactly what's acceptable and plan for the worst-case scenario. Then we get to the physiology. We have to give the bone marrow the building blocks it needs: iron, B12, folate, and then kick it into high gear with erythropoietin. The key ingredient in all of this? Time. This process takes weeks, which is why we often have to postpone elective surgery to get it done right. When we need to build up iron stores fast, IV iron is the only way to go. Forget oral pills. In many surgical patients, inflammation causes high hepcidin levels, which basically blocks iron absorption from the gut. As you can see here, we've got some great IV options. Something like ferric carboxymaltose lets us give a big 1,000 milligram dose in just 15 minutes. It's incredibly efficient for preoperative prep. Now, Rehupo is a powerful tool, but it's not a magic bullet. It's like pressing the accelerator on red blood cell production, but the car still needs fuel. And that fuel is iron, B12, and folate. It also takes time to work. But here's a crucial clinical pearl. You have to check the specific formulation you're using. Some brands contain trace amounts of human albumin. That tiny detail could derail your entire plan if that's not acceptable to your patient. All right, it's game day. We're heading into the OR. All that preoperative work has built up our patient's physiological buffer. Now the mission shifts entirely. Preserve every single drop of that hard-earned hemoglobin. This requires a deep, coordinated effort between us and the surgical team. So how do we do that? Well, there's no single silver bullet. The only way this works is by layering multiple strategies on top of each other. It's a combination of meticulous surgical technique, specific anesthetic management, and the smart use of technology, all working together to create as bloodless a field as possible. From our side of the drape, we have a whole range of tools. We can actively reduce bleeding with controlled hypotension, dropping the MAP to that 50 to 65 range. We can also use acute hypervolemic hemodilution, basically watering down the blood so each milliliter that's lost contains fewer red cells. And of course, a non-negotiable basic, we have to maintain strict normothermia. We all know even mild hypothermia wrecks coagulation. Of course, we can't do this alone. It's a true partnership with our surgical colleagues. It all starts with them being absolutely meticulous with hemostasis. They can also use energy devices like ultrasonic scalpels to seal vessels as they go, plus all the topical agents. And then there's the tech. Cell salvage, running that continuous closed-loop configuration we talked about, is an indispensable tool for giving the patient back their own lost red cells. Okay, so we've navigated the intra-op phase, but we are definitely not out of the woods yet. Let's talk about the drugs we can use to tip the scales in favor of hemostasis, and then how we manage that critical post-operative period where vigilance is everything. Well, we have a whole pharmacopoeia we can deploy here. With agents that work on different parts of the coagulation cascade, we can prevent clots from breaking down, boost the production of factors, or directly replace them in a crisis. The key is not to just throw drugs at the problem, but to be targeted, ideally using points-of-care testing like ROTEM or TEG to guide our therapy. This table lays out our toolkit really nicely. Antifibrinolytics like tranexamic acid are our bread and butter. They stabilize existing clots and should probably be used prophylactically. If things get really bad, we can escalate to factors like recombinant factor 7A. And if fibrinogen is low, we can give concentrate or cryo. But you have to remember, both are plasma-derived, so we must have documented patient consent for them beforehand. And look, if you need any more convincing on tranexamic acid, just look at the massive POISE 3 trial from 2022. The evidence for its use in non-cardiac surgery is crystal clear. As you can see, TXA dropped the composite bleeding outcome from nearly 12% down to 9%.
That's a hazard ratio of 0.76. It just confirms TXA as a cornerstone of our blood conservation strategy. The post-op period is where things can unravel fast if we're not careful. It's all about being hypervigilant. That means a low threshold for moving the patient to a higher level of care. One of our biggest enemies here is iatrogenic anemia by 1,000 cuts, from lab draws. We have to minimize phlebotomy with pediatric tubes, and our physiological goals are simple. Maximize oxygen delivery while we minimize oxygen consumption, all while continuing to support red cell production with our HUP. All right, for our final section, let's take everything we've just talked about and apply it to the ultimate stress test, what is arguably one of the biggest challenges in bloodless surgery, the liver transplant, a procedure that is historically synonymous with massive hemorrhage. This case report from way back in 1996 is just a beautiful example of this whole playbook in action. Look at what they did. Preoperatively, they worked for 4 weeks and took the hemoglobin from a dangerous 9.8 all the way up to a solid 14.1. Intraoperatively, they used every tool in the box. Postoperatively, they were aggressive with EPO. And even though the hemoglobin dropped to 6.5, the patient was successfully bridged through the crisis and went home. It just proves that with a meticulous plan, it can be done. And that wasn't a one-off fluke. A few years later, this case published in The Lancet really cemented the approach. Again, you see the exact same core principles. Aggressive pre-op optimization, a multimodal intra-op strategy using things like controlled hypotension and advanced surgical tools. Together, these cases proved that these techniques are reliable and repeatable, even in one of surgery's highest risk fields. So if you boil it all down, what's the recipe for success in these incredibly complex cases? It's this: a seamless, integrated strategy that spans the entire perioperative journey. It isn't one single trick. It's the powerful, synergistic combination of building them up beforehand, preserving what they have during the surgery, and supporting them vigilantly afterward. And this really brings us to the big picture, maybe the most important takeaway from all of this. The techniques and strategies that were developed out of necessity to care for our Jehovah's Witness patients, well, they've become the very foundation of modern patient blood management, or PBM. By applying these same principles to everyone, optimizing their own blood, minimizing loss, and harnessing their physiological reserves, we can reduce transfusion risks and improve outcomes for every single patient we take care of. What started as a solution for a specific group has gifted us a better way to care for everyone.